Thank you very much, and I appreciate the opportunity to be invited to such a distinguished group on such an exciting and innovative therapy. And I think this may be I don't want to drag politics in it, but this may be the few times that we can jump back and forth between the United States and Iran in talking about scientific stuff. And I am truly impressed by what you've been able to accomplish. And hopefully in the future, we can meet together in person and sharing this great science. As the sole cardiothoracic surgeon, as you mentioned too, I feel like I'm somewhat the scapegoat in some of these things to be among such great and amazingly smart people. So thank you for letting me participate. With the limited time that we have, I want to just jump in right away to talking about our experiences, at least in the United States, which are quite pale compared to what I think is being done in the rest of the world. And hopefully after educational activities such as this and the ELSO meeting a couple weeks ago, that there'll be some renewed interest in this, what I think is really innovative therapy. Next slide, please. I don't think I need to illustrate to the rest of the group how much of a problem COVID is at this time. And the fact that it appears to be getting worse across the world is even more concerning, with not only an ongoing number of cases, but also an ever increasing number of deaths, which appear to be somewhat constant around 2.5% across the world. And clearly there are areas that are hit harder than others. And here in Denver, Colorado, which is the view in my, out of my office compared to some of the other views, we are seeing more and more cases at this time also. And we are also looking for innovative therapies, as we have learned over the past 6 to 9 months, that a lot of the things that are out there really have not been really all that groundbreaking, in part because I think we're still trying to understand the best timing of things. Next slide, please. And part of this is linked to my interest as a cardiac surgeon in ECMO, and that is while ECMO is an excellent supportive tool for respiratory therapy for failure, such as in COVID, in helping preserve end organ function, lung perfusion, and oxygenation, it doesn't treat the primary problem. And I always make it an analogy to one of my favorite movies that you see here, and hopefully you guys remember it, and that is it's like bringing a knife to a gunfight. And sometimes we need better, stronger, and frankly, smarter therapies. Next slide, please. And to do that, I think we need to understand the morbidity and mortality that's associated with COVID-19 cytokine storm. Clearly, this is not a problem in all the patients, but from what we're seeing in our intensive care units, the ones that struggle the most really have a problem with the respiratory failure and associated cytokine storm as being the major sources of morbidity and mortality, in part from the uncontrolled and unregulated inflammatory and hypermetabolic response. And while ECMO is an excellent tool for stabilizing some of these patients, we do recognize that we're only dealing with part of the problem. And with such a distinguished group, I will lead the previous talks to sort of stand on their own because they did a much better job at explaining all this than I clearly could. Next slide, please. And so, our current hypothesis, which has prompted a lot of enthusiasm with our group for absorption therapies such as CytoSorb, is that by attenuating the cytokine storm, we can reduce the disease complications, multi-organ failure, the duration of symptoms, and even further clinical deterioration. And that's why we've really started to embrace this as potentially the best tool for all of this. Next slide, please. And I just want to illustrate 2 cases to help put this into a clinical perspective as the types of patients that we're seeing. So in our first case, a typical 44-year-old American male, 172 kilograms, with a variety of comorbidities, who presented with a week of weakness, fevers, nausea, vomiting, and generalized malaise, as well as a low-grade temperature. He was hypoxic in the emergency room, and he was started on convalescent plasma, subsequently found to be positive for COVID-19, underwent a 5-day course of treatment for remdesivir, continued to unfortunately deteriorate and was admitted to the intensive care unit, where the next day he was intubated in profound respiratory therapy failure. We checked IL-6 levels, CRP levels, as well as ferritin levels, and showed evidence of a pretty hypermetabolic cytokine response, really raising the question of what the next therapy was. Next slide, please. And so based upon his worsening deterioration, he was initiated on veno-veno ECMO. He did require renal replacement therapy. And at the same time, we did initiate the CytoSorb protocol. He also was treated with steroids, and within a relatively short period of time, his inflammatory markers showed signs of improvement as well as clinical improvement, and he was subsequently decannulated on hospital day 13. He was still COVID positive and subsequently self-extubated, or at least removed his trach, and ultimately discharged to a long-term care facility. And as of several months ago, he's home, doing well, off of dialysis and off of oxygen. And so while the question is, did the cytokine absorption help? It really raises the question as to whether earlier therapy may in fact be able to, quote, prevent or save patients from deteriorating to the point where they need ECMO, which is the basis of the next case I want to illustrate, which I think we're quite lucky to have some good data on. Next slide, please. And this also is a 54-year-old male admitted with 10 days of symptoms, promptly intubated upon arrival as he was quite hypoxic, started to experience worsening renal failure and needing renal replacement therapy. His ventilator settings continued to increase, as well as the need for vasoactive medications and worsening urine output. We did evaluate him for possible ECMO, as evidenced by our respiratory score, as well as predicted survival. However, the plan at the time, as he was relatively stable, was to initiate tocilizumab, renal replacement therapy, steroids, and then initiate CytoSorb absorption, and then go to ECMO within a relatively short period of time if he was failing these salvage therapies. Next slide, please. And this just illustrates the time course in the context of his ferritin and IL-6 levels. And I think it's quite impressive how you can see right after intubation that he had this profound increase in his ferritin level as a marker of his cytokine storm, and as further evidenced by his severe and profound respiratory failure and hypoxemia. We initiated both tocilizumab and CytoSorb-Therapy, and because of some mechanical issues on our end, we had to transiently stop the CytoSorb before we could complete the protocol, and that explains the profound drop in ferritin levels from starting the therapy, but prematurely stopping it, we saw that it went back up again. And then while we continued on with the therapy, his levels, which became unmeasurable, very promptly started to return back to normal. And this coincided with his clinical improvement with regards to his respiratory status, as well as his need for vasoactive medications, to the point where he was on relatively minimal ventilator settings within 4 or 5 days of initiating the CytoSorb-Therapy, leading us to believe that his clinical improvement was more or less directly correlated with our ability to filter out this, or excuse me, to absorb this cytokine response. Next slide, please. And so if you look at his time course, he was extubated within several days after completing therapy. However, he did require reintubation, had a variety of clinical problems, but was able to get over those to the point where he was again able to be extubated. He did require anticoagulation for a DVT. There was some concern of a small head bleed for which he was asymptomatic. And ultimately, at the beginning of June, he was discharged to rehab off of dialysis, I might add. If you remember, part of his presentation was acute renal failure. He was ambulating with reasonable oxygenation and ventilation. And then within a relatively short period of time, he was subsequently discharged back home, neurologically intact with baseline renal function and with room air. And you can see the progression of his x-rays from severe ARDS to improvement. Next slide, please. So as we start winding down, I want to at least emphasize what we thought were some of the pros and cons for this type of absorptive therapy. First and foremost was we strongly believe, based upon some of the existing data and our experiences, that it may reduce the impact of cytokine storms. It's extremely easy to use. It has minimal side effects in terms of filtering out or absorbing other types of stuff. We hypothesize that it may reduce the need for ECMO in critically ill patients. And in the context of everything else that's being used in these patients, it is relatively inexpensive. There are some potential drawbacks in that it does require cannulation and a pump, which is not exactly trivial. We're still trying to understand who may potentially benefit, how long, when to start therapy. Fortunately, we have a protocol, but not everybody that presents sick with COVID manifests COVID cytokine storm. We do need more data, and that's why we're so grateful for the investigators in this study. And many patients, as we start realizing, get better despite therapies that have been shown to be ineffective. And then likewise, many patients, unfortunately, still die despite some of these advanced therapies. So we have a lot to learn about these very sick COVID patients. Next slide, please. So in conclusion, many of our ECMO patients and cytokine storm patients are going home. Unfortunately, currently we have limited therapies for respiratory failure, and the current focus, particularly in the context of ECMO, is supportive care. The evolving therapies such as cytokine absorptive therapies are encouraging, but we still have a lot to learn, and managing the cytokine storm in the context of all this may be the potentially life-saving key that we all need. Absorption of inflammatory cytokines may be easier, safer, faster, and cheaper than many of the other high-risk medical therapies that are being offered. And at this point, I really want to thank everybody for allowing me to participate, as well as the wonderful team that I have here in Colorado that puts in a tremendous amount of time and effort in taking care of these critically ill patients. Thank you very much.